We welcome in today's talk show our esteemed viewers uh, in Dr. Tuteja talk show. Today's guest speaker is Dr. Chandrika Bhat from Bangalore, and she is consultant pediatric rheumatology services, Rainbow Children Hospital, Bangalore. She is consultant pediatric rheumatologist, Bristol Royal Hospital for Children, Bristol, UK, from 2016 to 2018. She's fellowship in pediatric rheumatology, Bristol Royal Hospital for Children, UK, 2011 to 2014. She is MD Pediatrics from Grand Medical College and Sir J. Group Hospital, Mumbai. MBBS from Kasturba Medical College, Bangalore. She is going to talk about the recurrent persistent fever, and she is going to update us about it. Our aim of life of this talk show is to update the society. If you like, you can subscribe it, our channel. Your suggestion, comments are always welcome. I welcome Dr. Chandrika ji.
Thank you, sir. Thank you very much for having me on your esteemed podcast. It's a great honor for me.
You can share your PPT if you want.
Okay, 1 second, sir. I'll just bring it up. Is it visible, sir?
Yes. So my first query is, what is recurrent fever and what is persistent fever?
So
And when should pediatrician think beyond the infection?
So, sir, I think fever हमारे लिए it's a very very common symptom all of us see in OPD practice में most of the times जो बच्चे आते हैं बुखार के साथ during a season of any infection they probably ज़्यादातर it is easy to know what the reason for fever is if it is flu season या RSV का season रहता है तो but obviously there will be that one of child who will probably have fever more than what you would expect for that particular season in that particular age. अगर बहुत busy OPD practice है तो this history at times may be hard to get because बहुत सारे parents बोलते हैं कि बच्चे को बार बार बुखार आता है तो इस सिचुएशन में कौन से बच्चे को और ज़्यादा हिस्ट्री पे हमें फोकस करना चाहिए कौन से बच्चे का डिटेल्ड एग्जामिनेशन करना चाहिए किसके लिए कितना इन्वेस्टिगेशन करना चाहिए दैट विल बिकम वेरी डिफिकल्ट ऑन अ डे टू डे बेसिस सो what I am trying to do is just to kind of prime everyone to say कि क्या सिम्टम या साइन है बच्चे में इन अ बिजी ओपीडी प्रैक्टिस कि हमारे ध्यान में आए कि नहीं इस बच्चे को हमें और थोड़ा इन्वेस्टिगेट करना पड़ेगा तो few definitions ऐसे नहीं कि definition we need to know it by heart but just a number will sometimes ring a bell to say कि नहीं इस बच्चे को और ज्यादा बुखार है than normal तो any child getting more than 3 episodes of fever और हर episode में fever डेली एटलीस्ट 3 दिन के लिए रहना चाहिए ऐसे नहीं कि आज एक दिन एक टेम्परेचर स्पाइक आए उसके बाद एक हफ्ते बाद एक ही टेम्परेचर स्पाइक आ रहा है दैट डजंट क्वालिफाई एज रिकरेंट फीवर एटलीस्ट 3 दिन लगातार अगर बच्चे को 100 के ऊपर टेम्परेचर आ रहा है 100 डिग्री फ़ारेनहाइट एटलीस्ट 3 times in a period of 6 months maybe this child will need some more attention probably we can take a much more detailed history कि बच्चा कैसा है during fever spikes in between fever spikes and बच्चा how the child is between these episodes of fever is very important अगर बच्चा पूरा नॉर्मल है इन बिटवीन फीवर एपिसोड्स देन वी क्लासिफाई दिस एज हैविंग रिकरेंट फीवर कभी कभार बच्चे के जो टेम्परेचर स्पाइक्स है बिटवीन दीज एपिसोड्स इफ द चाइल्ड इज नॉट कंप्लीटली वेल देन यू आर प्रोबेबली लुकिंग एट द सेम इलनेस दैट इज कंटिन्यूइंग बट प्योरली जो हम रिकरेंट फीवर बोलते हैं इसमें चिल्ड्रन आर यूजुअली वेरी वेल इन बिटवीन दीज एपिसोड्स ऑफ फीवर So also the other important thing is, अगर जब आप इन्वेस्टिगेट या इवेल्युएट अगर आप करते हो इस बच्चे को ड्यूरिंग दीज एपिसोड्स ऑफ फीवर, मेनी अ टाइम्स आपको कोई फोकस नहीं मिलेगा। ऐसा नहीं कि बच्चे को हर बार सर्दी खांसी लूज मोशन वॉमिटिंग है जिससे हमें पता चले कि कुछ तो वायरल इन्फेक्शन हुआ है बच्चे को। सो प्योरली फीवर विदाउट एनी अदर सिम्टम गोइंग ऑन फॉर एटलीस्ट 3 days, more than 3 times in 6 months, this child definitely has to be evaluated for recurrent fever. एंड आई एम श्योर मेनी टाइम्स ये डिसीजन लेना कि कौन से बच्चे को हमें डेफिनेटली इवेल्युएट करना है बहुत मुश्किल हो जाता है। बट आई थिंक 3 इज द नंबर ऑल ऑफ अस नीड टू रिमेंबर। 3 days, 3 episodes in 6 months is what needs to be evaluated. एंड अनदर वेरी इंपॉर्टेंट पीडियाट्रिशियंस के लिए ओपीडी में मुश्किल ये रहता है कि जो बच्चा फीवर के साथ आता है, परसिस्टेंट फीवर के साथ, in which temperature is at least 100 degrees or more, at least once in 24 hours, एक बार तो 100 टेम्परेचर टच करना चाहिए for at least 7 days, then this child classifies as having persistent fever. या कभी कभार बच्चे को पेरेंट्स इतना पैरासिटामोल आइबुजेसिक दे देते हैं आजकल की वॉट एवर इट इज फीवर को वो नॉर्मल कर देते हैं। देयर एम इज टू ब्रिंग द टेम्परेचर डाउन बिलो 100। सो अगर उस सिचुएशन में इन अ चाइल्ड हु इज गेटिंग फीवर, देन एटलीस्ट 2 weeks ऑफ सिम्टम्स आर नीडेड टू से दैट द चाइल्ड हैज हैड परसिस्टेंट फीवर। इसके लिए आई थिंक हैविंग समथिंग कॉल्ड अ फीवर चार्ट इज वेरी इंपॉर्टेंट, जिसमें हम पेरेंट्स को बोलते हैं कि एक डायरी में लिख लीजिए कि कितने बजे कितना टेम्परेचर आया था और उसके साथ क्या सिम्टम था बच्चे को, एंड आपने कौन सा दवा दिया है। तो उससे हमें थोड़ा आइडिया आता है कि ये जो टेम्परेचर है ये मेडिसिन के वजह से सप्रेस हुआ है कि एक्चुअली चाइल्ड इज डूइंग बेटर। तो एनी चाइल्ड हैविंग फीवर फॉर more than 7 days or more than 2 weeks with intermittent so-called afebrile periods due to medicine has to be evaluated for persistent fever. And when a pediatrician should think beyond just normal infection, which again ये बोलना आसान है बट इन क्लिनिकल प्रैक्टिस बहुत मुश्किल होता है फॉर एवरी पीडियाट्रिशियन, फॉर एवरी चाइल्ड टू से who needs this further evaluation. But just a few simple things we can remember is बच्चे में जिसमें more than fever is going on for more than 7 to 10 days, I would keep the cutoff of 7 days. 10 days थोड़ा ज़्यादा ही हो जाएगा. It is better to start at least priming the parents that child needs further evaluation after 1 week. एंड जिस बच्चे में हर टाइम फीवर के साथ और कोई फोकस नहीं है, जैसे हमने पहले डिस्कस किया था, सर्दी खांसी लूज मोशन वॉमिटिंग कुछ भी नहीं है, एंड इन सम चिल्ड्रन दे विल हैव फिक्स्ड पैटर्न्स विथ फीवर, जैसे कि हर बार फीवर के साथ ओरल अल्सर्स हो सकते हैं, हर बार फीवर के साथ साथ रैशेस आएंगे, या हर बार फीवर के साथ जॉइंट पेन होता है। इनफैक्ट कुछ ऐसे कंडीशंस है जिसमें पेरेंट्स कैन प्रेडिक्ट कि नहीं 2 हफ्ते में ज़रूर बच्चे को फीवर आएगा। सो एनीवेयर वेयर द पेरेंट कैन प्रेडिक्ट अ पैटर्न, जिसको हम बोलते हैं स्टीरियोटाइप्ड एपिसोड्स, दीज नीड फर्दर इवेल्युएशन। अगर आपने ब्लड टेस्ट किया एंड देन यू सी दैट बच्चे के इन्फ्लेमेटरी मार्कर्स विच आर सिंपल वंस लाइक WBC काउंट या CRP, आई हैव पुट इन फेरिटिन हियर, बट ये ज़रूरी नहीं है कि हर बच्चे में फेरिटिन करना है, दीज आर सेलेक्ट सिचुएशंस। बट जस्ट बेसिक ब्लड टेस्ट जो हम करते हैं जैसे कि CBC एंड CRP, उसमें यू फाइंड कि बच्चे का WBC काउंट विथ न्यूट्रोफिल डोमिनेंट WBC काउंट and CRP every time child gets fever it is very high, then we have to think that probably you're looking at recurrent episodes of inflammation in this child. अगर ये कोई कुछ इन्फेक्शन के वजह से है कि नहीं वो हमें सिम्टम वाइज या बेस्ड ऑन हिस्ट्री इवेल्युएशन पे वी हैव टू रूल आउट और कंफर्म, बट डेफिनेटली persistently high CRP every time with fever is not a good sign. और मेनी टाइम्स ऐसे होता है कि जब भी कोई भी हाई CRP वी सी ऑन रिपोर्ट्स, वी ऑलवेज स्टार्ट ऑन ओरल एंटीबायोटिक, दैट इज द टेंडेंसी ऑल द टाइम। बट अगर बच्चे का रेस्पॉन्स इज नॉट कंप्लीट टू एंटीबायोटिक, या आपको लग रहा है कि हर बार फीवर के साथ हाई CRP है आप एंटीबायोटिक दिए जा रहे हो, एंड समटाइम्स इट सो हैपेंस कि आप एंटीबायोटिक दो या ना दो, इन 5 days टाइम दैट CRP विल कम डाउन टू नॉर्मल because it might just be recurrent episodes of inflammation. High CRP always does not mean infection. Infection is just one reason for high CRP. तो इस situation में sometimes we have to take a step back and think, does this child actually need antibiotic every time they are getting fever? and symptom disproportionate to sign, matlab you're seeing very high inflammatory markers but child is running around, that again indicates that probably this is not an infection that you're seeing in the child. बहुत बार ऐसे होता है कि अगर इन्फेक्शन की वजह से बच्चे को हाई सीआरपी है, दिस चाइल्ड विल लुक अनवेल, दिस चाइल्ड विल बी डल, ओरल इनटेक पुअर रहेगा, most of the times they'll be sleeping even when child does not have fever. Whereas if the cause of high CRP is not an infection, this child will be extremely active when there is no fever, because these are just recurrent episodes of inflammation. So again, जब ब्लड टेस्ट और बच्चे का सिम्टम मैच नहीं हो रहा है, देन वी हैव टू डेफिनेटली स्टार्ट थिंकिंग बियॉन्ड इन्फेक्शन.
Will you tell us role of ferritin about it, as you have mentioned in?
Sir, ferritin is, I have put it here just to prime everyone regarding the importance of this test, but ये routinely हम लोग करते नहीं हैं. The basic tier 1 test we do to see if there is inflammation or not is just CBC, CRP, and if needed, something called the ESR, erythrocyte sedimentation rate.
Yeah.
But ferritin is not always needed. Ferritin is an acute phase reactant, and also in some infections, when they go into hyperinflammation or a complication called macrophage activation syndrome, the ferritin values become very high. So
Very good.
in temp fevers lasting beyond 7 to 10 days, sometimes even infections can complicate and children may develop macrophage activation syndrome. This may ferritin can go high. So this is just to say that there are a lot of tests we can use to know the degree of inflammation, and our focus should not just always be on finding out which infection. Many times we've seen that everyone is very comfortable sending repeat cultures almost every alternate day, sending repeat cultures, going on escalating antibiotics. Everyone is very comfortable with that. But if we tell them to send inflammatory markers and start medicines to control inflammation, that is always not very welcome. So this is just to say that please always think about the host response. It may not always be infection के वजह से हमेशा problem is not necessary. It can be that the child is reacting abnormally to that infection.
Next is definition and when to worry.
सो वरी जैसे हमने पहले डिस्कस किया था सर कि एनी चाइल्ड हैविंग रिकरेंट परसिस्टेंट फीवर डेफिनेटली नीड्स इवैल्यूएशन, और अगर if you are not able to find the focus of infection and child is continuing to have fever, then we need to start thinking about causes beyond infection. Now few things we say, at least in rheumatology, immunology, which are very important, is the pattern of symptoms that the child has. अगर बच्चे को फीवर के साथ क्या सिम्टम है, ये हर बार आइडेंटिफाई करना बहुत इंपॉर्टेंट है. सो फॉर एग्जाम्पल recurrent episodes of fever with oral ulcers, recurrent of episodes of fever with say redness of eyes, recurrent episodes of fever with skin rash. So this pattern where the same type of fever, same type of symptoms keep repeating, इसको हम autoinflammatory disease बोलते हैं, which is not as uncommon as we think it is. For instance, there is one very common autoinflammatory disease called periodic fever syndrome, जो सारे pediatricians ने देखा ही रहेगा, but many a times we don't recognize it. इसमें क्या होता है कि बच्चे को हर 6 to 8 weeks में, after the age of 3 years, they'll have start having fever spikes. Usually it lasts for around 5 to 7 days. The frequency more or less remains consistent. एंड उसके साथ या तो बच्चे को सर्वाइकल लिम्फ नोड्स रहेंगे, टॉन्सिलर एनलार्जमेंट रहेगा, या कभी कभी ओरल अल्सर्स रह सकते हैं. Such children always get oral antibiotics because everyone thinks it is bacterial tonsillitis. But this is a very common periodic fever syndrome called PFAPA, जिसमें आप एंटीबायोटिक दो या ना दो, in 5 days time fever will stop. So it is very important to recognize, because all these children need is reassurance. At times we can give NSAIDs like ibugesic, naproxen to control the degree of inflammatory response they have. But with age they tend to outgrow this. So अगर ये pattern हम अगर history में identify कर पाते हैं, तो this child will not be subjected to repeated unnecessary antibiotic use. So this is again the reason why we say whenever a child has more than 3 episodes of fever, getting a detailed history from parents with the associated symptoms of fever become very important. Now, I have just made this slide to show what are the patterns or different groups we can try segregating these children who have recurrent fever with. So the first group is what हम सब लोग देखते हैं, child coming with recurrent fever episodes but has very convincing symptoms for a viral infection जैसे कि सर्दी, खांसी, loose motion, vomiting. This is our routine seasonal infection, and depending on the epidemiology of that season, it may be easy to identify what infection it is. Now, the second group is wherein fever ke saath the child progressively or becomes more and more unwell. So, उसके साथ constitutional जो हम 20 type symptoms बोलते हैं, they will be present along with fever, mainly weight loss, some joint pain, bony pain, pain disturbing the child from sleep. Any sort of nocturnal pain in children should not be ignored when it is present with fever. And the presence of excessive night sweating. अगर ऐसा है तो definitely this child needs to be evaluated most importantly for malignancy. Apart from that, some atypical infections can also cause this and some autoimmune diseases. But most important is group में है malignancy, especially in a child with fever and bony pain. Leukemia is something we always have to have at the back of our mind. Now, the third group is where a child has recurrent fever episodes, पर हमेशा the organ system that is affected is the same. जैसे कि हर टाइम बच्चे को फीवर होता है and the child has urine infection every time. So then maybe there is a structural problem with the urinary or the renal system, genitourinary system. For example, 5-year-old boy coming with recurrent UTI, you would suspect a PUV. Yeah, a 3-year-old child coming with recurrent chest infections, one thing with failure to thrive, maybe cystic fibrosis because child is having recurrent lung infections. I'm just giving examples, but always if the same organ is getting affected with fever, we'll have to think of a structural issue with that organ, or it probably is an organ limited PID, example for which is cystic fibrosis. Now the fourth group is where it looks like एक ही episode of fever is going on. There are well days, there are unwell days. जैसे कि we just spoke about the definition of recurrent fever कि बच्चे को at least fever has to be there for 3 days, 3 times in 6 months. In between these episodes, child has to be well. This is recurrent fever. But in between these episodes of fever, if the child is still not looking completely normal, so parents may say that fever is not there, but something is not right with that child. It may be regarding appetite, it may be about a general activity, energy level of the child. Then you need to think about some atypical infections, and the classic one is Epstein-Barr virus, is what does this. Of course, tuberculosis is another infection in our setting we always need to be worried about. Now, the fifth group is child having recurrent fever episodes और हर बार कहीं ना कहीं तो infection मिल ही रहा है, but in a different organ every time, or the infection you're isolating is not common in the community, or the child has very poor growth, failure to thrive with this. This is the classic example of primary immunodeficiency or secondary immunodeficiency, which is HIV. So, different organ every time infection and unusual pathogens. This is the key. अगर ऐसा है तो we definitely have to rule out an underlying immunodeficiency. And the last group is what we just discussed, recurrent fever because of periodic fever syndrome, which is called otherwise autoinflammatory diseases. So this is just a very simplified way of putting it into different groups. This may be hard to get. Many a times ऐसे नहीं होता कि एक ही episode में we may be able to get this history. बार बार देखना पड़ता है. Every time revisiting the history becomes very important, and always going through the past records of the child. क्योंकि many times parents decide what is important, not important. They may not get some important records only with them. So going on asking them how the child was in the past, what tests were done becomes very important.
You have very well categorized the whole science, the whole fever in a different way so that it becomes very simplified for the pediatrician or general doctors to look a health provider to look after the fever in different categories. So please carry on.
And sir, just carrying on from that categorization that I did, few important things which immediately should prompt further evaluation are these red flag signs. Like I said, B symptoms, अगर weight loss है fever के साथ, night sweats, bony pain, any nocturnal pain, अगर बच्चे को persistent lymphadenopathy है, at least more than 1 centimeter in size, every time with fever child has hepatosplenomegaly, or there is serositis, pleural effusion, pericardial effusion. Yeah, there are other organ involvement, significant organ involvement in the form of behavioral changes, neurological involvement, or cytopenias of falling platelet count. Then we should always think beyond infection. These symptoms have put up, it can happen in infection, but it is just to say that these symptoms should start making the pediatrician more aware of other causes like malignancy or autoimmune diseases. Again, I've been very categorical in saying this, but काफी बार OPD में it becomes very hard to pick these things up, but it is just a rough guide to say what can help us think beyond the infection in children.
So what are the clinical clues and examination to diagnose recurrent persistent fever?
So before I go to evaluation, just to talk about clinical clues, the main thing again becomes the history that we always talk about. So history may again spending, sometimes we may have to spend at least an hour with the patient and their parents to get the entire history out about the past episodes. And I think what we usually say in rheumatology is 80% of our diagnosis we arrive with the help of history, 10% with the help of physical examination, and 5% with labs. So history absolutely is extremely important. And always it is better to go with through the history with parents in a very systematic way. Ask them exactly what date fever started, kitne din tak raha, what was the temperature recorded by them, how frequent was it, what were the associated symptoms. काफी बार ऐसे होता है कि they remember only the episodes they think were significant, and it may not always be significant for the child. If the fever interfered with their office visit, if they had to take unexpected leave from work, that episode of fever may become significant for them, even though it is not significant for the child. So getting this history, knowing कि हर fever episode में how sick the child was or how well the child was, what were the associated symptoms, and tracking the tests done, if at all they were done in the past with the symptom. कई बार ऐसे होता है कि they do the blood test after fever has gone, so everything may look normal, and we will not know that unless we get exact date wise symptom from them. अगर fever has stopped yesterday and today they have gone and given blood test just because they had time, obviously it will be normal. So again, it's very important to have a timeline of all the events from the time the fever started. Now, apart from that, when the child is in front of you for the current episode of fever, obviously we all do a detailed history taking for that particular episode की और क्या symptom है उसके साथ, and examination. And apart from that, for us, other important things we talk about in a child with recurrent fever, just with the history taking, apart from the past history, is how the child was during vaccinations. अगर हर बार vaccination के साथ the child has disproportionate fever or has some reaction to vaccine, so-called reaction to vaccine every time, that is also important to know if there is probably an underlying immunological disorder. Also, the other important thing for us is the family history. If there is any consanguinity, if a sibling also has recurrent fever, many times what happens is in these periodic fever syndromes like PFAPA, if you start asking, then parents say that nahi, even child's father also had the same problem, but after 15 he was fine. Yeah, child's aunt also had the same problem, but by the time she started going to college, she was fine. Usually there is a very strong clustering of these problems in families. इसके लिए asking them leading questions becomes very important, क्योंकि they may think this history of fever in the family member is not very significant because they became all right after 18 years of age. So again, asking leading questions in the history is very important. The other thing is also the travel history. If they have gone to an area where some infections, atypical infections are endemic, that becomes important. In Karnataka, we see that if they go to these forest areas, rickettsial diseases tend to be quite common. And unless we again ask for this history, it may be hard to identify this infection in particular. And third thing is the history of any pet animals at home. There have been instances, I recollect one child we saw with prolonged fever and lymphadenopathy was being evaluated extensively, always had high inflammatory markers, liver enzymes were high. And then ultimately we got the lymph node biopsy done, and on histopathology, the pathologist told us ki it could be toxoplasmosis. And then we
Oh,
went back, asked the parents ki any exposure at home, and they had like multiple cats at home. So that is again very important because the whole treatment then completely changes. So such simple things actually become very important in the long run. If at all you're looking at a child with recurrent, we
mm,
have to be like a detective in asking everything about what is happening around them. So I think this is the key about history. Again, an examination, obviously, agar first thing is the height and weight. I think one very important advantage we have in pediatrics is that agar any illness is significant, बच्चे का growth will falter. So that in a way will tell us what we are dealing it with is something very significant or not. So always charting the growth velocity with height and weight is very important. And also a very detailed physical examination, starting with general physical examination, looking at whether the child has pallor, any icterus, clubbing, all that adds to it. Lymphadenopathy is a very, very important symptom in a child with recurrent or persistent fever, क्योंकि they can either be reactive notes during every episode of inflammation, or that itself may indicate which infection, if at all it is atypical infections like TB, can be picked up. The other important thing I would say in a child with persistent or recurrent fever is skin rash. So कई बार ऐसे होता है कि skin rash parents may ignore it because it may come and it may disappear after a period of time. So asking them to take photos of the rash and coming back is very, very important. And we see this many times ki someone in the family would have said that no, this is just an allergic skin rash, इसके बारे में कुछ करने की जरूरत नहीं है. But actually, when we see, it will be a very typical evanescent rash of systemic onset JIA. So getting this sort of history from parents and asking them objectively to show those images, क्योंकि rash may disappear by the time you see the child. Again, one very classical example I can give is for Kawasaki disease, which we see in
mm,
children very routinely under the age of 5. उसमें क्या होता है कि all the symptoms that we use to kind of see if the child has the classic diagnostic criteria of Kawasaki or not may not be present at the same time. It may come and it may disappear by the time child comes to you on day 7. So unless you ask, क्या बच्चे को रेड आइज थे क्या, रेड लिप्स थे क्या, रेड टंग था क्या, रैश था क्या, you ask them to show photos, parents may not really think it is important. And one very common thing parents do is कुछ भी दवा देते, even if paracetamol they give and coincidentally they notice a rash, first thing they'll say is ये rash दवा के वजह से आया था. So again, asking this history to see what kind of rash it is very important, so that we also don't make that error in associating everything to a medicine. So I think again, detailed history, it is extremely, extremely important in recurrent or persistent fever. And from that, obviously, a very detailed systemic examination, which all of us would obviously do. Now, in evaluating these children with blood tests, these have to be guided by the clinical history. So I'm not saying कि ये जो list I have put up is the dictum कि हर बच्चे में सिर्फ यही करना है, ऐसा नहीं है. But these are some basic ones we would suggest after going through the detailed history and examination. So a full blood count with a differential count. This is very, very important in a child with recurrent or persistent fever. Um, Progressive drop in hemoglobin, the WBC count, whether there is leukopenia, whether there is leukocytosis, उसमें भी whether it is neutrophilic predominant or lymphocytic predominant becomes very important, be it infection or inflammation for both the causes, and the platelet count as well. Again, a low platelet count or a high platelet count. Thrombocytosis is also important because platelets are also acute phase reactants. So persistently, अगर हम thrombocytosis देख रहे हैं, we have to think about underlying inflammatory disorders. Other inflammatory markers, CRP, ESR, again is important. Ferritin in select situations, yes, I have again put this up just to say that ferritin is a very, very important test to pick up a complication called macrophage activation syndrome, which I think is heavily overlooked most of the times in children जिनमें prolonged fever होता है, because even if it is because of an underlying infection, um, even if you say have identified child has enteric fever, but if a child continues to have fever for more than 72 hours despite appropriate antibiotic, then you should be worried. Maybe this child is developing a complication called macrophage activation syndrome. So there, just going on escalating antibiotics is not the key, and that is where ferritin plays a very key role in picking up this complication. The other very important blood test I would say are liver enzymes. I cannot reinforce the importance of this. कई बार ऐसे होता है कि all of us think liver enzymes, if they are elevated, that means it is hepatitis, which is not the case. So liver AST, ALT, there are multiple sources of AST, ALT in the body. It can come from muscle, it can come from inflammatory cells, it can come from RBCs, or it can come from the liver. If the ALT is more than the AST, then it is purely coming from liver. You can safely say this child has hepatitis. But agar AST is more than ALT, then this is a part of a systemic inflammation or a muscle disorder. So in our routine practice, and whenever we see a child with prolonged fever, we ask for these tests together, a CBC, CRP, ESR, and a complete liver function test. It gives us a lot of information. And these are very basic tests which are accessible to most pediatricians. We don't need fancy tests. Based on this, we can decide कि आगे क्या ferritin भेजना है, क्या which infection, if at all you're suspecting, what culture, specific test for that infection have to be sent, or what test for an underlying autoimmune or autoinflammatory disease or malignancy has to be done. But I think if I have to say, these are the 5 key tests I would order in a child with prolonged or recurrent fever.
Very good. Very well explained by you. The next, we want to know that what are the practical investigation any pediatrician can offer.
Yeah. So again, जैसे सर मैंने बोला था about the basic test CRP ESR. One thing I want to emphasize is that ये जो हम CRP ESR test भेजते हैं, it has to be done from the same sample. ऐसे नहीं कि आज CRP किया, कल ESR करेंगे, परसों ferritin करेंगे, ऐसे नहीं होता है. It has to be done from the same sample, क्योंकि the correlation between CRP ESR again gives us a lot of information. अगर CRP is high, ESR is normal to high, it can happen in any acute inflammation or infection. This is the routine. कोई भी आप infection, bacterial infection या any inflammation is there, CRP will be high, ESR may be normal to high depending upon the day of fever. But agar if you're looking at ESR being very high and CRP being normal, either it could be a viral infection, but also very importantly, it happens in autoimmune diseases like SLE. If you see a child with prolonged fever, adolescent girl, if you order only CBC CRP, you may be falsely reassured that CRP is normal. We always have to ask for an ESR, because in a child with SLE, CRP will never be high. So always the correlation between CRP, ESR for us is very important. So one simple way of knowing is normal CRP, high ESR, it is either a viral infection or SLE unless proven otherwise. And obviously, we have to differentiate between the two based on the clinical history. If ESR is falling and CRP continues to increase, then this is something we call macrophage activation syndrome in a child in whom fever is persisting. So if I had to put it in a very simplified way, अगर बच्चे को persistent fever है, high ESR, high CRP, you're looking at a very inflammatory disease. Classic example is Kawasaki disease. If in a child with persistent fever, if CRP is normal, ESR is high, you're probably looking at SLE. In a child with persistent fever, if the CRP is very high, fever is continuing, ESR, which was high, starts falling, you're looking at a complication called macrophage activation syndrome. I think this is the key message to remember if anyone wants to take away 2-3 messages from this podcast today.
Yeah, this is very simple slide. uh, very well explained in only two tests how to differentiate acute inflammation, chronic immune activation, and autoimmune inflammatory disease. Very well explained. Next, we move to when to suspect specific conditions.
So, a few things again, I would like to talk from the history, sir. The pattern of fever, like I was describing. So, if a child has something, what we talk about as the quotidian pattern of fever, matlab, fever spikes are fixed 1 to 2 times a day, every day, with the child being very well in between. That is something we classically see in a condition called systemic onset JIA. Again, if a child has very fixed symptoms along with fever again and again, we think of a recurrent fever syndrome, commonly called the periodic fever syndrome, um, in which PFAPA, periodic fever, is very common. And we spoke about this, where the child will have fever, tonsillitis, some oral ulcers, raised inflammatory markers during these episodes. Now, there are some other recurrent fever syndromes, what we call the broader periodic fever syndromes, in which they tend to have very, very fixed symptoms along with fever. जैसे कि they'll either have a very fixed rash along with fever. Um, Now, depending on the type of rash, in fact, the more we see, we can in fact tell which periodic fever syndrome it is as well. जैसे कि there is one periodic fever syndrome, what we call as TRAPS, in which these children can have with fever always periorbital puffiness रहेगा, and they'll have these large sheets of erythematous rash over the body. It may last for around a week to 10 days, and this child invariably would have received antibiotics during the course. After that, whether you treat or not, this rash anyway is destined to go away. It will settle down. Again, next time when child gets fever, rash will come back again. अभी क्या होता है, many times this rash again is attributed to some antibiotic that is administered, and these children are falsely labeled as being allergic to ceftriaxone or some cephalosporin. So that is why I was telling earlier as well, like it's very important to ask them to bring photos of that rash and to know the timeline. So periodic fevers are very, very important. And when would you suspect periodic fever is anytime a child has more than 3 episodes of fever in a period of 6 months. So the child has to have recurrent fever. And every time fever ke saath, the pattern is very, very predictable. Like we described, either the rash will be there, stomach pain will be there, headache will be there, and they run the characteristic course. Many times the mother will be very confidently able to tell you when the next episode of fever will come and when it will stop also. So that should immediately alert you that this could be periodic fever syndrome. And the symptoms can range anywhere between joint pain, rash, conjunctivitis, and usually they don't have a cough, cold along with it. So there is no symptom of a viral infection with these episodes every time the child has fever. And many times we see this thing wherein parents come and say only during winter months our child gets fever, which we think that probably winter में child is getting recurrent viral, इसके लिए उसको हो रहा है. But actually many immune system problems can be triggered by exposure to cold. So in a child coming with recurrent episodes of a predictable pattern winter season में with the same kind of rash every winter, again please think of a periodic fever syndrome. Or if there is a family history of amyloidosis or early renal transplant for amyloidosis, it should make us think of an inflammatory disease. And I'll give you one example wherein we had this 8-year-old girl who came to us COVID time mein, where any child coming with fever of more than 3 to 4 days with very high inflammatory markers, people were diagnosing as MIS-C. And this child came in, usual symptom, had fever, had a rash, had abdominal pain, and was labeled as having MIS-C and started on steroids. And inflammatory markers bhi bahut high the. CRP, I remember, was around 250. So then we were given a consult because all patients coming with MIS-C were given a rheumatology consult. So when we went and asked the parents, they said, this time you're telling us it is MIS-C, पर ये तो इसके साथ हमेशा होता ही है. Even in the past ऐसे ही हुआ था उसके साथ. So then we said, okay, what has happened in the past? So the mother said कि साल में 2 बार इसको ऐसे फीवर आता है, last for around 10 to 15 days. हर समय ऐसे ही रैश आता है, स्टमक पेन रहता है, सिवियर नेक पेन भी होता है उसको. एक बार तो उन्होंने लंबार पंक्चर भी किया था उसके लिए. एंड एवरी टाइम वी आर टोल्ड योर डॉटर हैज टाइफॉइड. 2 हफ्ते तक एंटीबायोटिक चलाते हैं एंड देन शी इज फाइन. So then we said, okay, आपके family में और कोई significant history, anything is there? Then she said that my mother, that is the child's grandmother, she was around 50 years, is undergoing renal transplantation in Hyderabad. And my brother, which is the child's maternal uncle, has some problem for which he is seeing an adult rheumatologist. So that made us think, okay, this is probably not just Missy. Then we saw all the past reports, and every time she's had fever, she has very high inflammatory markers, CRPs 200, 300. That is normal for her. So we immediately told them, please get your genetic test done for the baby. And this child actually had a periodic fever syndrome called TRAPS, and which has an autosomal dominant inheritance. So her uncle also had the same problem. Her grandmother also had the same problem. And because no one identified the problem in her grandmother, she developed chronic renal disease due to amyloidosis and was undergoing transplant. So it's just to say how one diagnosis changed the course of management for the entire family. And then the uncle also got a diagnosis. They changed the medication he was on, and we were at least able to push him into remission. And hopefully, this child is doing very well now. So, this is just to say how the entire history taking becomes very important in these children. And of course, if at all you're looking at an adolescent girl with prolonged temperatures, fatigue, hair loss, very obvious rash on the face, photosensitivity के साथ है, we should start suspecting SLE, which I think many pediatricians are well tuned to picking up SLE in an adolescent girl. The other place where I think we need to have a bit more alert about symptom type of symptoms is immunodeficiency. So any child coming with recurrent infections, very significant, always needing IV antibiotics, has failure to thrive, unusual organisms if you're isolating, then please think about an underlying immunodeficiency.
So
So this is just one thing, sir, I wanted to highlight ki, this is something all pediatricians can have on their wall in the clinic, which are the 10 warning signs of primary immunodeficiency. It's a very simplified but a very effective illustration of the symptoms. So it talks about, we don't have to by heart these, but just to say recurrent ear infections, sinus infections, recurrent deep-seated infections, chest infections, or requiring IV antibiotics every time, like we were discussing, in a child who has failure to thrive, please suspect an underlying immunodeficiency.
very good slide. So when to refer before management before referral?
So I think management before referral, obviously symptomatic treatment is very important because that is what parents are looking for. We can go on talking academically what fever might be, but parent wants to see the child getting better. So symptom management, whatever is appropriate, has to be administered prior to referral. But when should a pediatrician actually consider referral is, of course, fever जब 10 या 14 days से ज़्यादा in a child it is going on, especially under the age of 5. And if there are any significant organ involvement in the form of falling WBC count, falling platelet count, neurological involvement, liver involvement, then they should be referred immediately. Until the time of referral, apart from supportive care, maintaining ABC, maintaining hydration, I think empirical antibiotics are warranted because in our country, still infections top the list for prolonged fever. So I'm not saying the take home message is not that infection is not common. That is still the most common reason for prolonged fever. So just stabilize the child, start empirical antimicrobials, and I think refer for further evaluation.
Anything?
So I think I've just put up this slide because काफी बार ऐसे होता है कि when the patient is there, many a times we are tempted to give one dose of steroid कि देखते हैं इससे शायद fever there will be defervescence, and this does happen very commonly. I'm not saying one dose of steroid will cause major problems. I don't think that is also the message we are trying to convey. But there avoid empirical that single dose DEXA shot, which we see very routinely being administered in a child with prolonged fever. If you're suspecting TB or malignancy as a probable cause, And even if you're sitting in a remote village without easy access to a tertiary care center, even if you're really tempted to give, please get baseline labs. अगर उसमें आपको लग रहा है कि child has neutropenia, if one cell line you have to focus on to make sure child does not have malignancy is neutropenia. At least if neutrophil counts are normal, if you're tempted to give steroids, a single dose I'm talking about, you may proceed until you refer the child to stabilize the child. As much as possible, please don't administer steroids. But in such situations, I think at least get baseline labs before giving any dose of empirical steroids.
So the final your message.
Yeah, final message, sir, is just
Urgent referral.
urgent referral only, like we already discussed, any organ involvement, child becoming unwell, it will warrant referral immediately. And until then, empirical antibiotics ABC has to be managed to the utmost ability of wherever the child is. And if one key message I have to say, it is that persistent or recurrent fever is it's a diagnosis in evolution. ऐसे नहीं है कि एक ही एपिसोड पे we will be able to identify what the underlying reason is, and it requires immense patience on the side of the treating physician and most importantly for the parents, which tends to be the most challenging part nowadays. Constantly telling them that we are trying to evaluate and it has to be a stepwise evaluation. ऐसे नहीं कि we can send all the tests together. We send tier 1, tier 2, tier 3, and to take them along with us on this journey needs a lot of patience and counseling for the doctors. So it's a lot of effort as a team that might be needed. And most importantly, the one take home message is please look at patterns. It's all about pattern recognition. Fever ke saath, what is the pattern that you're seeing is the key. Based on the pattern, you'll be able to decide what tests have to be done. And it is not a single event that is important, it's the timeline that is most important. And unless you're a detective who's going through every report, every symptom in detail and trying to see if there is a link, it may be very hard to identify what the cause of persistent or recurrent fever is.
Yeah. So Dr. Chandrika ji, बहुत ही very well explained a complicated recurrent undiagnosed fever in a very simple way with a simple slide, and बहुत ही आराम से आपने बहुत अच्छे से explain करा. And I am sure that the pediatrician of the country and Indian Academy of Pediatrics, they will be benefited by this talk in a simple way, and by precaution they will not use steroid as per explained to further come to the diagnosis in a right way, so that the children of our country remains more healthy and diagnosed in time. Thank you so much
Thank you,
for
sir. And
explanation.
just one last point I wanted to add, which I missed out, is please, I want to tell all pediatricians simply don't order a ANA test in a prolonged fever. It may cause
Yeah,
more problem than helping in these situations, unless you're very sure you're looking at an underlying autoimmune disease.
yeah. Thank you so
Thank you
much.
so much, sir.
Thank you so much being with us on this Dr. Trira talk show. And I will request all the pediatrician to subscribe the channel and send your comments to Dr. at YouTube to Dr. Chandrika ji, so that she comes to know what she can add more to the discussion which we had. And although she has explained in a very well way, but still, if some queries are there, her email and mobile number is on the first slide, and they can contact her. Thank you so much. Thank you very much.
Thank you, sir. Thank you so much for having me once again.
Thank you.